So we're going to talk a little bit about the upper extremities. This should be a review because I am going to touch on some things that you should have kind of learned along the way, but then I'll expand upon them and make them a little bit more applied and kind of apply them to cases or situations that oftentimes happen to people from a musculoskeletal injury standpoint. Okay, so the topics will be the following. So we're going to review kind of the course of the major nerves of the upper limb. We'll talk about myotomes and dermatomes, which I know is a concept that's been mentioned along the way, but I wanted to kind of help you work your way through those as well, because those actually are kind of sticky topics, and students do struggle with those at times. Kind of discuss the ways that peripheral nerves can be damaged, where they can be damaged, and then kind of what that looks like, how that manifests from a motor standpoint as well as a sensory standpoint, and then how ultimately it affects occupational performance. And those are the things I'm going to ask you to kind of reason through as we work through this discussion. And the other thing that I've found that's been really sticky for people is kind of an understanding of this extensor mechanism. It's a complex, really cool anatomical feature that we have, and it allows us to do cool things with our hands, but it is complicated. And the thing that I see that is pervasive is starting in semester 3 this summer and into semester 4 is the understanding of how your intrinsics work, specifically the interossei and the lumbricals. And I see that presenting itself again in the orthotics course because we do make orthoses that address weakness in those muscles. And then we do have a module again about orthotic interventions for people with nerve injuries. And I just see at that time again, frequently students struggle with kind of an understanding of this extensor mechanism and how the interossei and the lumbricals contribute to it and kind of what their roles are in hand function. So I wanted to be sure that we touched on that too, because I had a feeling that this wasn't addressed very successfully in this course, and it trickled down and affected learning in other courses. So we're going to start by talking about different ways nerves get injured, and for some of you this is a bit of a review if you've taken undergraduate anatomy courses, and which you all have, but I don't know how deep these courses get into topics like this vary. So I just wanted to start here. So nerves get injured in several different ways. One way being direct trauma. So a nerve can be cut, or what we would call transected, cut completely in half. It can be pulled away from where it inserts, and that's called like an avulsion injury. It can be stretched, where maybe perhaps the nerve isn't pulled away, but some of its axons, some of the neuron axons and whatnot are actually stretched and torn away, but not all of them. Gunshot wounds, I've seen a lot of people with gunshot wounds that have caused nerve damage, specifically gunshot wounds to the shoulder area, cause brachial plexus injuries, axillary nerve, radial nerve. Cumulative trauma is another way that nerves can be injured, and that's things like people resting on a nerve. So like if you rest on your elbow and your ulnar nerve gets irritated, just sustaining awkward postures, people that bend their elbows for a long period of time can cause ulnar nerve problems. Sustained awkward postures, for example, someone that types like this frequently, this decreases blood flow to the median nerve as it goes through the carpal tunnel, just those awkward postures, and so that actually irritates the nerve. Compression from other structures, so these nerves go through these very, in many cases, small canals, and there's a lot of structures that encase those canals, and those are oftentimes soft tissue, and soft tissue can be tight or it can be strangely composed. It can be that just anatomically speaking, we're different, and for whatever reason, our anatomy as an individual actually predisposes us to compression of these nerves. Disease can actually cause irritation of these nerves, so HIV, diabetes, thyroid disease, Guillain-Barré, which is kind of like an autoimmune disease that causes acute demyelinization of peripheral nerves, and it's very devastating. And then kidney failure, people that have long-standing kidney disease can actually go on to having peripheral neuropathies and whatnot. Drugs, So radiation treatment, for example, if someone's had a mastectomy and they're having radiation treatment to the axillary area afterwards, then that times can result in brachial plexus issues or other terminal roots that are kind of in that area. Chemotherapy can actually it can wreak havoc on our body in so many ways, and one of them is irritating nerves and causing nerve damage, and drugs that are used to manage seizure sometimes can cause nerve disruption as well. Okay, and this is important to understand because we'll be talking about where these nerves are injured from a compressive standpoint or a cumulative trauma standpoint. So peripheral nerves, we're going to talk a little bit about spinal nerves. We're going to talk about the brachial plexus. So basically, we're going to talk from proximal to distal. And we're going to talk about terminal nerve roots. And the basic function of these peripheral nerves is that they have motor function. And in most cases, they have sensory function. In some cases, they only have one type of function and not the other. Okay, so there are cutaneous nerves that have no motor function, and there are motor nerves that have no sensory function. Okay, but many have both. So we'll start by talking about the cervical nerve root. And if something's happening on your end and I'm not responding to it, if you're using the chat or anything like that, feel free to unmute your mic because all of a sudden my chat fell off the window here. There it goes. Okay, I can see it now. Okay, so cervical nerve roots. They exit through the intervertebral foramen, and basically from the level of C1 down to C7, they exit above the vertebrae. Okay, so as you can see here in this particular diagram, here they exit above the vertebrae. Okay, can you see my cursor or my mouse cursor here?
Yeah.
Okay, cool. So that's where they exit. So they exit above the vertebrae. Now, when we get down to the level of T1, the nerve roots actually that are named at the level of T1, for example, so the T1 nerve root, at that point they begin exiting below the vertebrae. Okay, and so this actually has some implication in terms of spinal cord injury, but that's kind of the distinction from basically from T1 down. The nerve roots begin exiting below the vertebrae. Okay, and so they're still named according. The naming convention stays the same. It's just that rather than exiting above the vertebrae, they exit below the vertebrae. Okay. And then the other thing that I've actually seen in some interesting diagrams of the vertebrae when diagrams have been put together to kind of illustrate spinal cord injury, and because there is a C8 nerve root, but there is in fact no C8 vertebrae, sometimes some anatomical models will actually show, just to illustrate problems with the spinal nerve, will actually show an 8th cervical vertebrae as well. So there is no 8th cervical vertebrae, but we name this nerve root C8 in this particular case because, yeah, so make sure that you mute your mic if you haven't already. In this particular case, because up until C1, all the nerve roots exit above the vertebrae, and then all of a sudden it changes, but we have one more straggler. We had to give it some sort of name, and so we gave it a C8 name. Okay, so basically from C5 all the way down to T1, these nerve roots all have upper extremity purpose. Okay. So spinal cord injury. Now, I know spinal cord injury is not injury to a peripheral nerve, but it obviously affects the function of peripheral nerves. And the two things that I wanted you to kind of take home from this is that what happens with a spinal cord injury is that sensory and motor dysfunction below the level of the injury are disrupted. Okay, and I know you've already had a module on this in the 6202 course. But I just wanted to reemphasize this. And the way that we in rehabilitation go about describing spinal cord injuries, so when you hear someone being described as having a C6 or a C7 or a C5 quadriplegia, for example, the way that we go about naming these things is that we name them according to the level of injury of the lowest functioning spinal nerve. Okay, so for example, if the injury has affected the spinal cord in a way that the C6 nerve root still functions and it still sends its motor information and receives sensory information, then it's a C6 quadriplegia. That means that basically the spinal cord injury was at like the C7 level or lower. Okay, but we name a when we're describing the spinal cord injury. Okay, the convention that we use is to name it according to the lowest level of function that they have, or I guess you might also think of it as being the highest level of function. Okay, so that's just kind of important. It's not based on necessarily where the injury occurs; it's where they still have function. All right. So with the C6 quadriplegia or tetraplegia, that means that the C6 nerve root is still functioning because the spinal cord is injured below that level. Okay, that's the naming convention that we use in rehabilitation. Right? So I just wanted to clarify that particular issue. Okay, and that leads us to the next topic, which is dermatomes. Okay, so this is a diagram of basically two things. It illustrates on the pink side or the peach side of the body, it illustrates the cutaneous innervation patterns. Okay, so these are basically those terminal cutaneous nerves that obviously originate at some point from a spinal nerve, but they're more refined. Okay, so these you can see here where these little compartments right here where a cutaneous nerve actually gives us sense information from this region. Is in most instances very, very compartmentalized, very small. Okay, and conversely, though, a spinal nerve is responsible for cutaneous innervation of a larger segment of our body because it's more proximal. Okay, and you know, as you've learned, the brachial plexus is basically a compilation of these spinal nerves. And so if you take it one step backwards, then you're going to see that, you know, things are less messy. And so the innervation, the cutaneous innervation patterns of the spinal nerves are broader, longer, and more easily defined. Okay? So when a person has a spinal cord injury or a spinal root nerve root injury, the cutaneous changes that they're going to experience are going to be in a dermatome, okay, not necessarily in a cutaneous innervation pattern. So that's the one thing that I wanted to emphasize, because I've seen in my own practice where I'll have a client that will come in with what they believe to be carpal tunnel syndrome because they'll have, you know, sensory changes in the palm of their hand, you know, kind of in the radial side of the hand, but it's also that they have, in some instances, they might have changes in the palmar surface here, and changes that might even stem back into, you know, the radial side of the forearm. And in that case, and maybe even some, you know, extending further up into the lateral anterior portion of the upper arm. And in that case, I'm starting to sense that, well, this isn't really carpal tunnel syndrome. This is something happening more proximally, meaning that there's maybe a brachial plexus issue, maybe a cervical nerve root issue. So it gets me thinking about, okay, well, this is probably something happening more proximally. And a lot of people believe that a lot of these more distal compression type of syndromes that people experience are at times often because there's irritation of their nerve more proximally. And that is referred to as a dual crush phenomenon. Okay. But I just wanted to clarify that point. Okay. So there are these distinct cutaneous innervation patterns that occur. These are the ones that are specific to cutaneous terminal nerves, and these are the cutaneous patterns that are specific to. Someone was chomping on his ear. Okay, I hope it was delicious, Hannah, and nutritious. You know, hopefully it's something like, you know, bran or something. But anyways, I wanted to just have those distinctions for you. Okay, I hope that helps. So the other thing that's important to understand is that, like these dermatomes, the spinal nerves are actually responsible for innervating particular muscle groups as well. Okay, and and that's why what you've learned about in the spinal cord injury unit of compensation teaches you that at certain spinal cord levels, at certain spinal cord injury levels, only certain muscle functions are available to the client. Well, that's basically just an illustration of a myotome. Okay, so for example, at a C5 level, then that C5 nerve root helps us move our elbow, essentially. Okay, so it's responsible ultimately for innervating our elbow flexors. Okay, we move one level down, and the C8 or C6 nerve root is responsible for helping us extend our wrist. Okay, so that's why when a person has a C6 spinal cord injury, they have wrist extension. Okay, meaning that the injury is below the level of C6. Okay, at C7, then our elbow extensors start to kick in, meaning that when a person transfers at the with the C6 quadriplegia, and they're resting into their arms by straightening their elbows, they're not straightening their elbows because their elbow extensors are available to them, because they're not if they have a C6 injury or C6 level of a spinal cord injury. Okay, the elbow extensors aren't available to them because that's a C7 innervated muscle group. So they're basically just resting on the ligaments of their elbow and just locking those elbows in place when they go about transferring. Okay. At the C8 level, then we're going to start getting some long finger flexors involved. We might have our flexor digitorum profundus available to us. And then at the T1 level, then that's when we start getting our intrinsic muscles kicking in. Okay? And then, of course, the same is true as we get into the lower extremity. There are also myotomes there as well. So these myotomes basically help us understand what type of muscle function should be available to a client with a certain level of a spinal nerve injury or a certain level of a spinal cord injury. Okay. But that's an important thing to understand. So spinal nerve injuries, so we're just moving further proximally, or further distally here, oftentimes occur due to a bulging disc, or at times they can just be avulsed away from the spinal cord. Okay, it's just due to some sort of acute trauma, motor vehicle accident, something like that. Okay, sometimes they can actually be torn away. But with another way that, yeah.
Can you hear? So just going back to the whole dermatomes and myotomes thing. So when I'm trying to think about this in my head, so myotomes are like muscle, and dermatomes are where you could, like dermatology, where you could feel it on your skin, but it isn't necessarily where it's originating from. Yes? No?
Exactly. Yeah. So a derm always refers to skin, and myo always refers to muscle. And yeah, so obviously, like at the at like C6 dermatome, which is kind of over here per se. Obviously, that's happening all the way. The problem is happening all the way, or the cutaneous innervation is stemming from the C6 nerve root, but its manifestation, the sensory information that it actually is responsible for carrying back up to the central nervous system is coming from this part of our hand, for example, or this part of that make sense?
Yeah, I think so. So because it's like that's where we're feeling it, because we're feeling it there, like on our skin or whatever. So that's why it's a dermatome.
Yep.
Yeah, but then otherwise, like the myotomes are. Okay.
Yeah, so the nerve root is responsible for basically allowing for the sensory receptors in that part of the hand to communicate their information up to the brain.
Yes.
Or to the spinal cord.
Yeah.
Yep, good question.
Okay.
Yep. That help?
Yeah.
Yep, dermatomes are for feeling, myotomes are for movement. Yep. Okay. Let's see. Okay, so back to the spinal nerve injury. Like I said, they can be torn away. The other thing that sometimes happens is discs, as we age, actually become degenerative. I mean, they actually degenerate over time, those discs between our vertebrae. And because of that, the space between the discs, and I'll show you a slide here in a second that illustrates this, the space between the two becomes less, so the vertebrae are closer to each other, and that nerve has less room to exit between those vertebrae. So it's also compressed in those issues. But what happens here is that the muscles in those myotomes or in the sensory information coming through those dermatomes is changed as a result. Okay, so it could be that the muscles are completely paralyzed depending on how severe the injury to the nerve is, or it could be that they're just weakened because only some of the axons that find their way down to the muscle have been damaged. And the same is true for some of the axons carrying sensory information back into the central nervous system. So that just depends on the extent of the injury to the nerve. Okay. So for example, if we had a T1 nerve root that was damaged, then according to the myotomes that we just learned about, you would expect to have weakness in the interossi, the lumbricals of the ulnar side of the hand, the hypothenar eminence, the adductor, we'll get into this, the adductor pollicis, the deep head of your flexor pollicis brevis. We'd expect to see weakness in those areas, if not paralysis in extreme cases. Okay? So, and this just kind of illustrates those myotomes and those dermatomes again. So for example, at the C5 level, if we had an injury at C5, we'd expect to see either a loss or diminished sensation in this part of our arm. We'd expect to see weakness in our deltoid and our biceps. Okay. C6, we'd expect to see sensory changes here. We'd again expect to see changes in the bicep, but then we'd also, because, bicep is innervated by both, right? And then we'd expect to see extensor weakness, wrist extensor weakness. Okay, C7 has a very small portion of our body represented in terms of its cervical, or in terms of its dermatome. It's a very small dermatome. Okay, but from a motor standpoint, it's pretty extensive, right? We wouldn't have finger extensors, we wouldn't have triceps, and we'd lose some wrist flexors along the way too. Okay, so you can see how that kind of progresses on, but this is a nice way to illustrate the type of motor and sensory function that would be diminished with a cervical nerve root injury. Okay, and then this is a nice graphic that I stole. I didn't have time to go about citing these, but I can do that for educational purposes. But here you can see a bulged disc, and here you can see a spinal nerve coming out, and you can see that as indicated in red here, that nerve is not happy because this disc is actually bulging out laterally and compressing on the nerve. Okay, so that's just kind of to illustrate the herniated disc. The other thing that's happening here is, as you can see here, you have a nice healthy disc with a nice intervertebral joint space, and then here you see this joint space actually narrowing. Okay, and that's another reason why this nerve can be injured as it comes through the intervertebral canal. So the brachial plexus, as we've learned, is formed by the C5 to the T1 spinal nerves. Okay, and their pathway, and this is an important thing to understand because it kind of helps us understand where they're prone to problems, is that they first exit through the anterior and the middle scalene. So they exit through there, and then they come underneath of the collarbone or the clavicle, and between the clavicle and the first rib, which you can't see quite so easily, but it's this right here. Here's the first rib. They travel through that space as well. Okay, so that's called the costoclavicular space, right? So between the costal or the first rib and the collarbone, okay, or the clavicle, costoclavicular. So then they travel through that space, and then lastly they go over the basically underneath the coracoid process and the pec minor. Okay, so we all remember that the pec minor comes in and inserts on the coracoid process. So you can see not only the brachial plexus, but also the brachial artery, subclavian brachial artery traveling through that area as well. Okay, it's prone to being compressed along with the brachial plexus in these three locations. Okay, so the brachial plexus can be irritated as it travels through the scalenes. It can be irritated and compressed as it travels underneath the clavicle here, and then it again can be compressed or irritated as it travels underneath the pectoral, the pec minor. Okay, So that's important to understand because there's a condition, there's a slew of conditions referred to as thoracic outlet syndrome. And thoracic outlet syndrome is probably a term that you've heard of before, but basically what it means is that the brachial plexus is irritated in one of these three sites, or it's being compressed in one of these three sites. And thoracic outlet syndrome also refers to the vessels, the blood vessels, potentially being compressed in those locations as well. So you can have one of two types. You can have a more of a neurogenic or basically irritation to the brachial plexus, or you can have more of a arterial or a vascular compression occurring during thoracic outlet syndrome. Okay, but I just wanted to understand kind of the course of the brachial plexus as it travels basically to the level of the humerus. So lots of ways that the brachial plexus can be injured. The first illustration here that I have is just to kind of illustrate what we would call a stretch injury, or in some cases maybe an avulsion type of injury, where a person has traumatically fallen onto the side of their neck. So the three areas that the brachial plexus could be compressed would be through the little triangular area formed by the anterior and the middle scalene. Okay, that's called the interscalene triangle. That's actually what it's called. And then the space underneath of the space between the first rib and the collarbone or the clavicle. And then the last space that can be irritated is under the pectoralis minor muscle. Okay. So a fall, a traumatic fall of some sort like this, where you land onto the side of your neck and onto your shoulder, can cause a stretching of the nerves, okay, the brachial plexus. So that's one way. Trauma, direct trauma. Like I mentioned earlier, a gunshot wound to this area could obviously cause damage to the brachial plexus. Radiation after mastectomy, for an example, like I mentioned earlier. Another way that the brachial plexus can be damaged is during birth. So this, for all of you here that want to work with kiddos, you sometimes might see kids with what's called Erb's palsy, or a brachial plexus injury that happened during birth. And what happens is sometimes during birth, very rarely, but sometimes, the child's shoulder gets caught on the birth canal as it's exiting. And that's referred to as a shoulder dystocia. And you can imagine it has the same sort of effect on the brachial plexus as does this type of injury. Okay? And the result of that when the child is born is that they actually have some partial paralysis of the upper extremity. It damages the upper trunk of the brachial plexus. Okay? Another way that it can be damaged, as you can see in this x-ray right here, we have a very bad break to the collarbone. Okay? And the shards of the bone or the jagged edges of the bone can actually irritate and damage the brachial plexus because, as I mentioned earlier, the brachial plexus travels right underneath of it. Okay? And then I mentioned already that compilation of different areas where the brachial plexus can be compressed is referred to as thoracic outlet syndrome. That's another way the brachial plexus can be injured. Okay? And you expect to see sensory dysfunction basically in all those cutaneous innervation patterns and muscle function of the decreased terminal branches of the brachial plexus as well. Okay? So I mentioned a condition called Erb's palsy earlier when I was talking about problems with birth and the brachial plexus injury that occurs at birth. Like I said, that was referred to as Erb's palsy, and that's an upper trunk injury. Okay, and you can imagine if the neck is being stretched right here, the upper trunk is the one that's going to take most of the brunt of that particular trauma. And this is how it would manifest. I'm not going to read through this in detail, but you can see here this is how it would manifest. The radial nerve, it said be C5 and C6, so you'd have radial nerve problems, you'd have axillary nerve problems, you'd have suprascapular nerve problems, meaning that your rotator cuff would be weak. And then conversely, though, you can have more of a lower trunk issue. So that's basically CAT1, and that's what we see more commonly with thoracic outlet syndrome. because the compression is typically occurring onto the lower trunk. Okay, and that would be primarily ulnar nerve, right, or medial cord. Ultimately, that becomes kind of the medial cord of the brachial plexus. We would see medial cord or ulnar nerve problems, essentially. Okay, so that would be basically we would see a loss of cutaneous sensation or diminished cutaneous sensation in the C8T1 distribution. So thinking back to the dermatomes for C8T1. And then also we would expect to see motor dysfunction of the intrinsics of basically the ulnar nerve innervated muscles of the upper arm as well as into the hand. Rhonda, go ahead and just ask your question if you wouldn't mind. Or type it in.
Hear me?
Yep.
Okay. Sorry, I didn't want to interrupt you, but kind of going back to the spinal cord injuries, I'm not sure if I misheard you, but I think you said something like if a client has a C6 injury, it's below the level of C6, so they would still have like wrist extensor function, or did I mishear you?
Yeah. So it's kind of so when we say
below that level, or
right. So when we say C6 quadriplegia, what that means is that the injury was below C6.
Okay.
It was at the next level below it. So that means that they still have C6 nerve root function.
Okay.
So that in that case,
like
yes, they would have wrist.
Okay. So whatever like
Yeah, but it's confusing because right, they would have sensory and they would basically have sensory and nerve function, sensory and motor function in the C6, C5, C4, C3, C2, C1 nerve roots.
Okay,
everything above that injury.
Still have the function of whatever nerve is innervating C6, but then from C7 down is disabled, basically.
Yep, and it's confusing because it's confusing. It's muddy because when we hear people say C6 spinal cord injury, we oftentimes assume that the injury has to be at that level, and basically what it's telling us is that they still have function at the C6 level.
Okay, great.
So when a person is referred to as having C6, yeah, that's a good question. If a person has C6 tetraplegia or C6 quadriplegia, it's because at the C6 level and above, things are working.
Okay, thank you.
Okay. Yep. Okay, so let's see. What do you see about what are the presentations of these particular photos that you see here? So on the kiddo, describe using kinesiological terms the postures that you see the affected arm posturing in. So the wrist is posturing in what? Let's go ahead and unmute.
Flexion.
What? Flexion, okay. And the forearm is posturing in? It can be one of two things, supination or pronation. Pronation. Okay, the elbow is posturing in elbow flexion or extension?
Extension.
Extension, okay. The shoulder is posturing in internal or external rotation?
Internal.
Internal, okay. And the reason for all those things is that this is basically a C5, C6 injury. Okay, so this is the upper trunk of the brachial plexus that has been damaged, and it's responsible for being able to do all the opposite motions. That's why the arm is posturing the way it is, because this kiddo can't extend his wrist, this kiddo can't flex his elbow, this kiddo can't supinate his forearm, and this kiddo can't externally rotate his shoulder. Okay, so that's why that's a typical posture for a person with an Erb's palsy, for a kiddo with an Erb's palsy, is that internally rotated shoulder, elbow extended arm, pronated forearm, and flexed wrist. Okay, so that's why it looks that way, because all the muscles that are innervated at the C5 and C6 level, in this case, aren't working. And this kiddo, you would also expect to have sensory disturbances in those areas too. Okay, and then thoracic outlet syndrome is what we're seeing in the picture on my right. And which hand do you think is affected by thoracic outlet syndrome in that picture?
The left one.
The right or the left, and why?
Because of the little finger and the slight flexion of all of the fingers, and it's a little bit different color.
Mm-hmm. Yeah, it actually is a different color too, and so you wonder if there's not a vascular problem there as well. Yes, so this person actually is displaying some clawing, and we're going to talk a little bit about the phenomenon of claw hand, right? But claw hand occurs when we have basically weakness of our interossi and our lumbricals, and they're primarily innervated by the ulnar nerve, which is a C8-T1, or lower trunk nerve, essentially. The ulnar nerve stems from the lower trunk of the brachial plexus. Okay, so that's why this is a photo of kind of what that would manifest, what thoracic outlet syndrome would manifest, how it would manifest in the hand. Okay, I'm not going to. This slide is just for your benefit. I'm not going to walk you through this. This is very busy, but I think it really does a nice job of illustrating the branches of the brachial plexus and the muscles that they're responsible for. It was a nice diagram that I came across, but I'm not going to walk you through this. It's very complex. Okay. We're going to transition into talking about the terminal branches of the brachial plexus, in the major ones. Okay. You guys doing okay?
Yep.
Okay. Excuse me. All right. So we're going to talk about the radial nerve, the musculocutaneous nerve, axillary nerve. We're going to talk about the long thoracic. We're going to talk about the ulnar nerve and the median nerve. Okay. But this is just kind of putting all that into context and illustrating their cutaneous innervation patterns as well. So first of all, we're going to talk about the axillary nerve. Okay. So the axillary nerve, as you learned, arises from the posterior cord of the brachial plexus. Okay, and it travels through the quadrangular space, which is this space right here. Okay, that's formed by, this is the teres minor that's been cut. It usually doesn't look like this, but it's been cut, right? So it's formed by teres minor here, and then it's formed by the long head of the triceps, and by teres major, right? And then, of course, we can't see it, but also formed by the humerus. It's gone in this picture. So it travels through the space that looks like a square, right? And it's prone actually to damage to this area. So sometimes due to hypertrophy of some of the muscles in this area, it actually can be irritated. So sometimes bodybuilders will actually damage the axillary nerve by hypertrophying some of these muscles, making them so big that they actually occupy more of the space so the nerve can't get out so easily, right? And then after it travels through that space, it divides into an anterior and a posterior branch. Okay, and then also has its own little cutaneous nerve that comes off as well. Okay, so basically the the anterior branch gives us sensory information to the anterior and the middle deltoid. Okay, the posterior, so it makes the muscle fire. It's a motor nerve, and then the posterior branch of the axillary nerve supplies teres minor and posterior deltoid. Okay, and then it continues on and actually terminates as the superior lateral brachial cutaneous nerve. Okay, so it comes out here. That's what this blue thing is. And it actually gives us cutaneous innervation to the lateral part of our arm here. Okay, so that's the axillary nerve. So as I mentioned, it can be irritated in the quadrangular space, and sometimes overhead athletes might experience this. Like I mentioned, bodybuilders might also sometimes cause this problem. People have shoulder pain kind of in the lateral or posterior aspect of their arm, and then they'll have weakness in the muscles, in extreme cases, paralysis of the muscles that are innervated by it, so deltoid as well as teres minor. it can be treated oftentimes conservatively through maybe a steroid injection to that area or therapy that where we might work to stretch those muscles and make them looser so they're not causing so much injury or so much damage to the structures that come through there. Another way that these can be damaged is actually due to surgery that actually wasn't intended to fix them. So like arthroscopic surgery at the shoulder where they're going in there exploratorily to try to figure out what's happening, let's say with the rotator cuff. Sometimes that can inadvertently damage other structures, particularly this nerve. Okay, and how this looks is like this. Okay, so you can see compared to the unaffected side here, where you've got a nice middle deltoid muscle mass here and anterior deltoid muscle mass. There's extreme wasting right here. So this would be a very advanced case of this problem, of this particular injury, right? So extreme wasting here. And then, of course, there would be wasting of the teres minor muscle as well. So this is an anterior view, so you can't see that. But this is like an extreme case of an axillary nerve injury. Okay. So now here the question to you is, what type of motions would we expect to see diminished, okay, as a result of this axillary nerve injury? Go. The deltoid makes what movements happen?
Abduction.
Okay, middle deltoid is abduction.
And then
What else?
extension and flexion of the
Posterior deltoid extension.
Yeah.
Yep, posterior
Anterior
extension.
flexion.
Flexion. Do they help with rotation? Do the anterior fibers produce any sort of rotation on the humerus? They internally rotate, right? And the posterior fibers externally rotate as well. So, yeah, you would expect to see motion changes in basically strength changes in those particular movements, right? Would we expect to see sensory changes, and where would that be?
Can you repeat the motion that it would affect? I didn't quite get all of it fast.
So it's basically all the motions that the deltoid produces, and of course the teres minor. So the deltoid produces, on the anterior fibers produce flexion, they produce internal rotation, horizontal adduction. Posterior fibers produce external rotation, extension of the shoulder, horizontal abduction, and the middle fibers produce abduction. Specifically abduction kind of above the level of like 15 degrees of abduction. So as you're getting from here on up, that's when the deltoid does its magic. Okay, and then the teres minor is responsible for what movements?
External rotation.
External rotation. Anything else? That's its primary function. So yeah, we would expect to see, not only because the posterior fibers of the deltoid aren't working, but also because teres minor isn't working so well, we would expect to see problems with external rotation. Okay, so that could be very bad for an overhead athlete. Okay, so what occupations would you expect to see trouble in? Just throw out some. So this is kind of how we go about using our activity analysis, right? Excuse me. What type of occupations would a person just think across the board in all aspects of their life, in all areas of occupations?
I would say like getting dressed, the upper body, like putting on a shirt.
Yeah.
Probably
putting overhead dressing.
showering.
Yep.
Cooking.
Hair care.
Things like that. Yeah, hair care, grooming.
Yeah. Meal preparation, reaching above your head to grab something off a shelf, that would be somewhat affected, especially, I mean, we would have some weakness. We would still have some shoulder flexors working for us. We would still have the long head of the biceps helping out. But yeah, there would be weakness. So any sort of overhead activity would be diminished. Anything requiring external rotation of the shoulder, I mean, we don't think about this, but so much that we do on a daily basis requires a lot of external rotation.
Would driving also be affected? I know it's not extreme flexion required, but kind of having to have his arms on the wheel and turning it and things.
I think so, and especially it's things that are sustained in nature, right? So anything that requires like sustained like flexion or sustained overhead use, we still have other muscles that can help make some of those things happen. But we've lost some, and so to sustain those means that we're working with only a certain amount of muscles, right? And that means that they're more prone to fatigue. So yeah, I think anything that requires sustained shoulder abduction, flexion, extension is going to be a problem. Okay, does that help? Okay. Excuse me. So the musculocutaneous nerve, it arises from the lateral cord of the brachial plexus, and then it travels through and pierces the coracobrachialis muscle, and it travels right through it. And then it splits, and then it also innervates the biceps, and it innervates the brachialis. Okay, so it innervates those three muscles. And then ultimately, it terminates as the lateral antebrachial cutaneous nerve. Okay, so it gives us cutaneous information from the lateral aspect of our forearm. Right? So that's what its responsibilities are. It innervates those three muscles, and then it provides cutaneous sensory information from the lateral forearm. Okay? So it's not a very complex route that it travels. It's pretty simple. And its function is pretty simple. This gentleman had a musculocutaneous injury, and it's kind of hard to see because you can't see his other side, but there's profound wasting of his biceps. And what muscle? He's actually trying to flex his elbow right now. What muscle can you see visibly here that's doing the elbow flexion work? The bicep isn't.
Brachioradialis?
You can see a muscle visibly. What's that?
Is it the brachioradialis?
Yep, that's the brachioradialis, right? You can see this muscle popping out right here, and it's doing all the work right now, right? Because this is a radial nerve innervated muscle. So it's still functioning. Musculocutaneous isn't functioning, but median nerve or radial nerve still is. And so the brachioradialis is doing all the elbow flexion right now. And you can notice that it's happening with the elbow in a neutral position like this, right? Can't really show you, but the elbow is neutral, like the forearm is neutral. Okay, and that's because that's where the brachioradialis makes the elbow flex. Okay, it can't supinate the forearm as the elbow flexes like the biceps. So what elbow flexion, like if you want to bring your hand to your mouth when you have no musculocutaneous nerve innervation, it's going to be like this. Okay, you can probably supinate to some extent, obviously, with the use of the supinator. It's still functioning, but it's going to be a very weak elbow flexion. I mean, you only have one muscle here producing elbow flexion, and it's not the primary elbow flexor, right? So elbow flexion is going to be markedly weaker, right? And so this happens for a variety of reasons. It can happen due to a gunshot wound, basically when a person's had surgery to the arm. Sometimes it can be damaged. And then shoulder dislocation. So if a person has extreme shoulder dislocation, it can actually be torn during the dislocation. Okay? So I don't think we need to go into the motions here, right? But let's think about beyond elbow flexion. Are there other motions that would be weakened by musculocutaneous damage beyond elbow flexion?
Mentioned supination.
Okay, supination would be weakened. We'd still have the supinator, but the biceps wouldn't be helping supinate the forearm. Any other motions that would be weakened? What other movements does the bicep, the long head of the bicep in particular, help to make happen?
Is it
The long head of the bicep is a shoulder flexion. It's a two-joint muscle. It crosses the glenohumeral joint, and it also crosses the elbow joint, right? So because it crosses the glenohumeral joint anteriorly, it helps to flex the shoulder. So we would have some weakness in shoulder flexion as a result, although in theory we'd still have the deltoid. What else? Let's think about another muscle that we've lost that has more than one role.
Coordination of the forearm.
Yes. What muscle are you thinking about in particular?
Brachialis?
Brachialis? What about coracobrachialis? What else does it do besides flex the, or what are its jobs?
Adduction.
It does. Yeah. So humeral adduction, bringing the humerus into the body, and one other. Does it also help to flex the shoulder? Okay, so yes, we would expect to see some weakness in shoulder flexion because the long head of the bicep isn't working, because coracobrachialis isn't working, and the ability to tuck in their arm like this is going to be a little bit weakened. We still have other muscles. Where would we expect to see sensory changes?
Tingling or burning in the elbow?
Yes. Yeah, so a person would maybe have burning sensations or numbness and tingling or complete numbness, and it would be on the lateral aspect of the forearm, okay? Because that's where the lateral antebrachial cutaneous nerve, which is the terminal aspect of this nerve, innervates. That's the cutaneous distribution of that cutaneous nerve. Okay, so after the musculocutaneous has done all of its work as a motor nerve, it sends fibers on down further into the lateral forearm, and then at that point it changes its name into a lateral antebrachial cutaneous nerve. Antebrachial refers to basically the forearm. That's what antebrachial means. Okay, brachial means basically the upper arm. Antebrachial means lower arm. Okay, so yeah, basically all motions that the biceps, the coracobrachialis, and the brachialis produce will be weakened. Okay, and then what kind of occupational problems might a person have? Just go ahead and start throwing them out there. We know that we're going to have weakness in those areas that we just described. What type of occupations require those movements?
So like brushing your teeth? be more difficult, or?
Sure. That requires, in most cases, supination, elbow flexion.
Household
Okay.
cleaning.
What about things that are a little bit more resistive?
Like lifting anything?
Yeah. What's like when we go to the grocery store? We usually walk out with bags, right? So carrying those bags, lifting those bags into the car, that would be challenging, right? Because that would require some resisted elbow flexion. Of course, if your occupation is exercise, if one of your daily occupations is exercise, working out at the gym, doing what was that?
Playing a musical instrument.
Sure. Depending on what the instrument was, for sure.
Childcare.
Childcare, for sure. That's huge. You have a big baby to carry around, or even a toddler to lift up off the floor when they're misbehaving or in a tantrum or whatever the case may be. So it could certainly affect childcare. Lifting dishes. Tina said lifting dishes into the cupboard. You bet. So a bunch of them. This could be a very profoundly devastating condition. Obviously, we have the other upper extremity, but a lot of the things that we do on a daily basis are manual in nature. They require the use of both of our hands to carry out a task. So this could be profound. Now, when we think about the cutaneous sensory changes, that's probably perhaps not as profound, right? If we lose sensation to the lateral part of our forearm, that's usually not as much of an issue. Now, as we lose sensation in the hand that's responsible for fine motor, prehensile type of activities, that's a problem. Okay, which leads into the next topic, which is the median nerve. Feeding, yeah, Rhonda mentioned feeding. Yeah, so I think feeding could be a problem, right? Just bringing your hands to your mouth. Perhaps it could still happen. It might just be that the ability to supinate might be lessened. So supination is kind of a bit of a process that we go through when we, feeding, if you think about it, usually what the utensil requires is some pronation first, and then a little bit of supination, and then some elbow flexion, and some more supination, and maybe some radial deviation, things like that, as we're bringing it closer to our mouth. So yeah, perhaps some of that, especially at the end when we're actually bringing food to our mouth. So the median nerve is not as simple as the musculocutaneous nerve, and its roles are bigger. It's a complex nerve, and it basically has fibers, as you learned as you guys mapped out that brachial plexus. It has nerve fibers that come from the C5, C6, C8, T1 nerve roots, right? So it has basically nerve fibers that are coming from every single cervical nerve root that sends information through the brachial plexus and receives information through the brachial plexus. So ultimately, the medial and the lateral cords contribute to this of the brachial plexus, right? And they form the median nerve. And it runs through kind of the anterior compartment. Okay, so the anterior compartment is the group of muscles on the anterior side of the humerus, and the posterior on the posterior side. So it kind of runs to the anterior side, but medially close to the humerus, and then it transfers. It crosses, as you can see right here, as it begins crossing into the forearm. It enters between the pronator teres. So here's the pronator teres actually cut away, and then the biceps. The biceps actually has a structure that I'll show you in the next slide. That's called. Okay. So it also travels underneath of that aponeurosis, or basically it's like fascia. Okay. And then it emerges. It travels between the flexor digitorum superficialis and profundus, so it travels between them, and then emerges all the way down here further between the flexor digitorum superficialis and the flexor pollicis longus. Okay. And then ultimately it ends. It'll travel through, this is the transverse carpal ligament right here, and it'll travel underneath the transverse carpal ligament. Some of it will travel under the transverse carpal ligament along with the tendons of flexor pollicis longus and the tendons of flexor digitorum profundus, those 4 tendons that it contributes, and the 4 tendons of flexor digitorum profundus, so superficialis and profundus. So it travels through the carpal tunnel with 9 other structures, okay, which is why it's prone to being compressed in that area, right? But before the carpal tunnel, it actually emerges, or it actually has another branch that it sends off called the anterior interosseous nerve, okay? So after the median nerve travels underneath the pronator teres, which you can't see very well, and cut away, okay, but here's the pronator teres. After it travels underneath of that, on the other side of the pronator teres, it actually sends a branch off called the anterior interosseous nerve, okay? And that anterior interosseous nerve only has motor function, okay? And the anterior interosseous motor function is that it innervates the flexor digitorum profundus to the index finger and the middle finger. And then it also innervates the flexor pollicis longus that flexes our DIP joint or our IP joint of our thumb. And lastly, it innervates the pronator quadratus. And I'll show you that more so in another slide here. Okay, so it has its role is to innervate 3 muscles, or basically 3 muscles that doesn't innervate all of the flexor digitorum profundus because the other side of the flexor digitorum profundus is innervated by the ulnar nerve. Okay, so the flexor digitorum muscle that goes to the portion of the muscle that goes to the small finger and the ring finger is actually innervated by the ulnar nerve. Okay. And then another thing that happens before the median nerve enters into the carpal tunnel is that it actually sends off a palmar cutaneous branch, and that's what this is right here, coming off. And that cutaneous branch doesn't go through the carpal tunnel. It actually comes in here and gives us sensory information to the palm of our hand. That's what its job is, okay? So after the median nerve goes through the carpal tunnel, so that it sent off its sensory branch that innervates the palm of our hand here, and then it continues down through the carpal tunnel and exits the carpal tunnel and sends off a branch that innervates our thenar muscles called the recurrent motor branch of the median nerve. And then it continues to innervate 2 more muscles of the hand, which are our lumbricals, to our index finger and our middle finger. After it innervates the thenar muscles, it goes on to innervate the lumbricals to our index finger and our middle finger. And then from that point forward, it becomes strictly sensory. Okay, its sensory branches are first the common, so it sends off like 3 common sensory branches, common digital sensory branches, okay? And basically it's common, it's called a common branch until it enters to the finger and bifurcates. Okay, so it's going to bifurcate before it gets to the finger, split off, and then it sends off a branch to the outside of the index finger and to the inside of the index finger, and those are called the proper digital. Okay, so it goes common, and then it splits and sends off a branch to each side of the finger, and those are the proper digital cutaneous branches of the median nerve. Okay, and it sends off a branch to this side of the index finger, this side of the index finger, this side of the middle finger, this side of the middle finger, and then this side of the ring finger. Okay, and it's also sent off sensory branches up here to the thumb, each side of the thumb as well. Okay, so that's why the median nerve is responsible for the cutaneous innervation of this portion of the hand after it's crossed the carpal tunnel. And before it crosses the carpal tunnel, it's responsible for this part of our hand. Okay? Right? Any questions about that? It's complex, but when we talk through it, I think it helps a lot. Okay. And then I found this really cool diagram that helps to illustrate at what point muscles are being innervated by the median nerve, stripping all of the muscles out of the way. It does a really nice job of illustrating this. So basically at the level of the medial epicondyle, okay, which is right here, we've got these forearm flexors, or basically these forearm muscles that originate, okay? The first one being pronator teres, that comes across here. You can't see that. Then the flexor carpi radialis, which comes down here. And then palmaris longus, which comes down here and inserts into the palmar aponeurosis. And then flexor digitorum superficialis. Okay, so it innervates those three things first. Then, like I mentioned, after it crosses past the pronator teres, it sends off another motor branch that innervates the flexor digitorum profundus to the index finger and to the middle finger. And then the flexor pollicis longus, which is responsible for flexing the IP joint of the thumb. And then lastly, it sends off a motor branch to the pronator quadratus. Okay? The median nerve continues its path after sending off that anterior interosseous nerve, and then it branches off and sends off a cutaneous branch right here, okay, which is that branch that I mentioned earlier, right here, the palmar branch, right? And then it travels through the carpal tunnel, and it gets those, the thenar muscles, the first two lumbrical muscles, and then it continues with its cutaneous function as well into the fingers of the radial side of the hand. Okay, and this is the median nerve cutaneous distribution pattern right here, and here it is on the dorsum. So it does also give us a little bit of cutaneous innervation or cutaneous information from the dorsum of the thumb, the dorsum of the index finger, the dorsum or the backside of the long finger, and then the dorsum of the radial side of the ring finger as well. Okay. The radial nerve is what's going to give us sensory information right through here. And then the ulnar nerve is going to give us sensory information through here and through here. And we'll get into that in a second. Okay? You guys doing okay?
You know, this is so helpful to me. I don't know how
Okay.
everyone else feels, but this is, going through it like this is super helpful.
Cool. Anyone else? Anyone lost? Anyone need me to review something? It's okay. Feel free to speak up. Okay. So here we go. Onward. So common sites of injury to the median nerve. So I mentioned earlier that the median nerve first travels kind of underneath the pronator teres muscle, and here it is right here. So here's where the medial epicondyle is. Here's the pronator teres. And then the bicep, this is the bicep right here, and here it is coming down to insert on the radius. The bicep actually sends off a bicipital aponeurosis, okay, so it's just basically connective tissue. It's also referred to as the lacturnus fibrosis. So those two terms are used interchangeably, okay? But that's what this is right here. And so it kind of wraps around the pronator teres, right? So as it comes through this area right here, the median nerve actually can be irritated. It can be irritated right here, okay? And right here on this border of the pronator. And so that happens, as you can imagine, as a person repetitively pronates and perhaps hypertrophies the pronator teres. That causes less space through here. It also just happens because this connective tissue, this aponeurosis right here, can be pretty jagged on this border of it, and so it's just prone to injury right here. So surgeons will call this two things. They'll either call it lacturnus fibrosis syndrome, or they'll call it pronator syndrome when the nerve is being irritated right here. Okay, there are like different schools of different camps where some people believe it's happening because of the pronator is irritating it. Other people believe that it's just because this connective tissue is irritating it. They're just different camps. Okay, and then the other place that it can be irritated is at the carpal tunnel. Okay, and as I mentioned earlier, there are 9 tendons that are occupying that space that's formed by the carpal bones, as well as on the volar surface or the palmar surface, the transverse carpal ligament or the flexor retinaculum. So the transverse carpal ligament is a portion of the flexor retinaculum. Okay, so that's the surface, the volar surface of it. Okay, so that's its roof, so to speak. Okay, so it can be injured, it can be irritated right there under as it goes through that tunnel, because that space can be pretty narrow at times. And another thing that predisposes people to having less space in that area is when the flexor tendons become thickened. So disease can cause those flexor tendons to thicken, like diabetes. Another thing that can cause them to thicken is when they become swollen and irritated from overuse. Okay, so they can actually develop like a tendonitis, essentially, but it's called a tenosynovitis in this case. Okay, so as they become thickened because they're swollen, because they're inflamed, they occupy more of the space, and the median nerve has less room to do its work. Okay, so that's another place that can become irritated. Okay, now it's also prone to being so that's more like cumulative trauma. That's what we would call more of like cumulative trauma, but it's also prone to direct trauma.
Corey,
at the level of the carpal. Yeah.
what's becoming inflamed, the nerves or the muscles?
Both. So it's like a chicken and the egg type of phenomenon. It could be that the tendons are inflamed first, okay, and then because of that they swell up and they occupy more space and the nerve becomes compressed. Or it could be that the nerve is just irritated all in and of itself because of awkward postures that a person might adopt, or because they have diabetes and that changes the circulation to a nerve. One can cause the other. Like tenosynovitis can cause irritation to the nerve because it makes the nerve have less space to work through, and it makes it more compressed. And carpal tunnel syndrome, yep, Rhonda, carpal tunnel syndrome is when the median nerve is being compressed as it goes through the carpal tunnel. And so as we mentioned earlier, what carpal tunnel syndrome looks like, and the function of the median nerve we described earlier after it exits the carpal tunnel, right? So all of its functions after it exits the carpal tunnel are going to be diminished because the compression is happening at that level. So as I mentioned earlier with carpal tunnel syndrome, or as I mentioned earlier, now related to carpal tunnel syndrome, motor function to the thenar muscles is going to be impaired when the median nerve is not doing its work after it crosses the carpal tunnel. Sensory function to this side of our hand out here is going to be diminished, right? And that's why people will have numbness and tingling with carpal tunnel syndrome, or they'll have pain in the nerve distribution, like sharp shooting pain that is nerve pain. Okay, they'll also have weakness in the lumbricals to the index finger and the middle finger. Okay, that's how carpal tunnel syndrome manifests. Okay, and it's because, as you learned earlier, the function of the nerve after it exits the carpal tunnel is all those things that we just described. Okay. So Tim, did I answer your question?
You did, thank you.
Okay. All right. So yes, carpal tunnel syndrome is when the median nerve is innervated at the level of the carpal tunnel. Okay. When it's injured, or it's compressed and irritated right there. So this is how it might look. So for example, on the left here, this is a client with an anterior interosseous nerve injury. Which of the two hands do you think is impacted by this injury?
Left one.
The left one. Tell me why.
They're not able to flex their fingers and like the opposition kind of the thumb into the index finger is not able to flex correctly either.
Yeah, what joints in particular don't you see flexion happening in on the left side?
I would say PIP and DIP.
Yeah, mostly the DIP, right? Because what two muscles do we not have working that actually flex the distal phalanx of the thumb and the index finger? So what muscle is responsible for flexing the IP joint of the thumb? What muscle flexes the tip of the thumb? It's a flexor, and it acts on the thumb or the pollicis. Okay, thumb is anything that says pollicis is referring to the thumb, and it's
Flexor pollicis brevis.
not the brevis, because the brevis is not innervated by the anterior interosseous nerve.
Okay.
It's innervated by the median, or the median nerve after it crosses the carpal tunnel. So there's only one other flexor of the thumb, not the brevis. The longest, the flexor pollicis longus, is the one that, as I mentioned earlier, is innervated by the anterior interosseous nerve. Okay, and so it's responsible for flexing the IP joint of the thumb, right? And in this side of the hand, you can see the IP joint's flexing very well, right? And then also the anterior interosseous nerve, like I mentioned, innervates the flexor digitorum profundus, and its responsibility is to bend the DIP joints. That's what flexor digitorum profundus does, primarily. Right? And you can see in this picture, this person's doing a nice job of flexing their DIP, whereas on this side, they're not. Right? So basically, the ability to make an OK sign, right, and the inability to make an OK sign is what's telling us that the left side is the one that's injured. Okay? So if a person can't form an OK sign that looks like this, it might be telling us that the anterior interosseous nerve is not functioning appropriately. That make sense? So I would go about testing anterior interosseous nerve function by asking a client to form an OK sign, and then I would pull my finger through there to see if they can resist it. And if they can't even form the O to begin with, if it looks more like this, right, then that's pretty telling. But maybe they're able to partially form it because the muscles still are working, and then I would just compare it to the other side, and I would pull through to see how quickly it broke or how easily it broke. Conversely, though, on this side of the hand, this is a person with advanced carpal tunnel syndrome. What things do you notice about it?
Muscle atrophy.
What muscles appear to be atrophied? Where do you see muscle wasting? What part of the hand?
Like the thenar muscles.
Mm-hmm. Yeah. And so they are innervated by the median nerve after it crosses through the carpal tunnel, right? So you can see, like, just look at your own hand, and then look at these, and most of you probably don't have advanced carpal tunnel syndrome like this, right? But you can see there's huge amounts of wasting, even on this side more than this side, right? So this side's more advanced than this, likely, okay? But, and it gets to a point where the nerve is basically no longer sending motor signals, and because of that, the muscle wastes, right? Because the nerve has been so severely damaged. And that's what we're seeing here. This is advanced carpal tunnel syndrome. It really shouldn't have never gotten this far along, right? But yeah, so And there would likely be also wasting of the lumbricals, which are harder to see, but there would likely be wasting. And there's not much to the lumbrical to begin with. It's a small little wormy-looking muscle, which is actually what it means in Latin. Lumbrical means worm in Latin. Okay? So, yeah, profound amount of wasting right here. And then we would also expect to see sensory changes through here. Okay? Maybe not here, because like I mentioned earlier, that's where that nerve before the carpal tunnel syndrome actually gives us thenar or like palmar sensation, right? So it's the palmar branch of the median nerve that actually gives us this area. So person might have intact sensation right here, but it's going to be, especially in this guy's case, it's going to be numb through here. Okay? Now, ways that this is treated for anterior interosseous nerve compression in particular is, here's the anterior interosseous nerve right here. This is a photo of surgery. Okay, and here is the pronator teres. So this is the proximal arm up here, and this is the distal arm. So here's the pronator teres, and it actually is being cut. Okay, and that they call that a step lengthen release. But basically, it's just it's doing our surgical release, cutting through the fibers of the muscle to actually release its tension as it lies over top of the anterior interosseous nerve. Okay, they likely also cut the lacturnus fibrosus, okay, or the bicipital aponeurosis. They likely also cut that as well. But that's one way that they would go about taking compression off of that, so the anterior interosseous nerve works better, right? Something that we might do as therapists when that anterior interosseous nerve isn't functioning to help them compensate for the lack of its function is we might make an orthosis like this, or some people call these splints, right? What motion do you think this is helping a person accomplish? What posture is it putting their IP joint or their thumb in?
Flexion.
Thumb flexion, right? Which is something when the anterior interosseous nerve isn't working, can't happen. So if a person was trying to pinch forcefully, right, the thumb and the index finger would collapse into this type of position, right? Which isn't very helpful when we're trying to do prehensile type of activities, right? When we do things that require really fine motor, right? It requires like a tip-to-tip pinch like this, right? Where we don't want a lot of surface area intact, or basically coming in contact, right? We want a small amount of surface area, right? So when a person has an anterior interosseous nerve problem, it's going to collapse like this, and it makes picking up fine objects very difficult, right? So we might make an orthosis like this to better enable them to flex their IP joint. Conversely, we could put one over top of the DIP of the index finger too, to help support it in pinch. Okay? Because we know the DIP joint would also be affected of the index finger. So we could also add a thing that looks just like this to the back of the index finger as well. And so that we do from a compensatory standpoint. This would be something that we would do to help them substitute for the function of that muscle as the nerve is healing, for example. Like after the surgery, or even before the surgery. Okay, does that make sense? So this is us doing our thing, and this is a surgeon doing their thing. And after the fact, we might actually help to strengthen, for example, the muscles that the nerve innervates after its function is returning, right? We might help to strengthen them through the use of therapeutic activities and the use of preparatory things like exercise. Okay, so what about if there's been damage happening at the level of the carpal tunnel, either through, like I mentioned, the compression that can happen to the nerve, and then in some instances, people will either have an accidental injury to the median nerve, like through a laceration, like through a cut through this level of the wrist. And sometimes when people are intentionally cutting themselves at the level of the wrist, a suicide attempt, when they're attempting to cut the radial artery at the level of the wrist, they also cut the median nerve, right? So I actually, when I worked in acute care, I did not work in the psychiatric portion of the hospital, so I did not do psychiatric OT, but I was consulted on many occasions to go into the psychiatric area to kind of treat, to help stabilize a median nerve repair for a person that tried to commit suicide. And so I'd make a splint basically to protect the repair, put them into a position like this so that no tension was on the median nerve after it had been repaired. Okay, so I have worked with people that have had suicide attempts and have cut not only the vessel but the nerve as it travels through here. So what we might do as therapists for people that just have nerve compression, there are a lot of things that we might do, but one, for example, to address the fact that when we stay in long periods of time in flexion, like this, it actually cuts off circulation to the median nerve. We might make an orthosis to help keep the wrist in a neutral position, right? And that should take the pressure off the median nerve to allow it to heal on its own. Okay. What a surgeon would do to relieve pressure on the median nerve is they'd go in there and they would cut either the entire flexor retinaculum, or they would just cut a portion of it called the transverse carpal ligament. And that takes pressure off the structures beneath. That's what a surgeon would do. Okay, so this is them doing it with an open incision, and others will do it through endoscopy. They'll use an endoscopic type of approach where they just stick in a small instrument that allows them to visualize the carpal tunnel syndrome, or carpal tunnel, and then they'll just use an endoscopic type of procedure to cut the ligament, which is less invasive. And then this is something we might do to help a person that has had a profound injury to the median nerve. Like in this case, this median nerve for this person right here was completely cut in half, and so none of their median nerve innervated muscles after the level of the carpal tunnel are working. Okay, even with the repair, they're not going to be working. Eventually, they'll be working after the repair, but not for a long while. Okay, so why might we make an orthosis like this after the median nerve isn't working whatsoever? What would the purpose of an orthosis like this be? What position is it putting the thumb into? What would we call that?
Horizontal abduction?
So it could be called palmar. We would call it palmar abduction. But what is the finger also doing relative to like the index finger? What would be the position that it is in relative to like the index finger?
Like opposition?
Opposition, yeah. So it's opposing the index finger, right? And what are the three thenar muscles? What are their names? It goes OAS, from radial to
Flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis?
Yep, pollicis. Yep, that's right. So it's OAF from radial to ulnar side of it. O, opponens, pollicis. Okay. Then it's abductor pollicis brevis, and then most medial is flexor pollicis brevis. Okay. OAF. Okay. So the opponens is gone in this particular case. So we might make an orthosis like this to allow the person to actually oppose their thumb so that they can do prehension. Okay. One other thing to mention is that when a nerve is cut in half like this, even if the two ends are sewn together, you're going to get more into nerve healing next semester when you take the neuroanatomy course. Okay, but basically all of the axons from the point of the injury distally die. They all die. The benefit to sewing two nerves together is that the outside of the nerve, which is called the epineurium, which is basically just like fascia, it's like connective tissue. Okay, it actually is a vehicle for those neurons to find their way back home. If you don't have the epineurium surrounding those axons as they're trying to grow back to where they belong, they don't always go where they need to go. So that's the benefit of sewing the nerve together. Even if all those axons from the point, those nerve axons, even if they die, which they will, from the point of the injury backwards, or basically forward or distally, they're all going to die. Sewing the nerve back together actually helps those axons find their way home appropriately. Okay, so that's the benefit of doing that. Because that's called anterograde degeneration of the axon. And you guys will get into that a bit more next semester. Okay, so motions. And after this, maybe you want to take like a few-minute break. What motions will a person have a hard time doing with a median nerve injury at the level of the wrist, whether it be a cut nerve or carpal tunnel syndrome?
Any type of finger flexion.
Finger flexion? So the lumbricals are going to be weak, right? So the lumbricals, their responsibility is to help flex the MP joint and extend the IP joint. So they're going to be a little weak, yeah. So it'll be harder to flex. It'll be weaker to flex MP flexion, and IP extension will be a little bit weaker on that side. What about the thenar muscles? What motions do they help produce?
Opposition.
So opposition, yep. So it opposes the metacarpal, the thumb metacarpal. It rotates the metacarpal into opposition. What else? What does the flexor pollicis brevis do?
Flexes the thumb MCP joint.
Okay, so that'll be weakened. And then what about the last thenar muscle?
Abduction.
Yeah, so it'll be hard to produce this motion. Okay, it'll be weak. You'll still have the abductor pollicis longus, right? Because it's radially nerve innervated. We'll talk about that here in a second. But yeah, it'll be weakened. So the ability to bring the thumb away from the palm will be weakened. Right? Okay, and then of course you'd have all the sensory changes of the median nerve. Right? And what occupations would be hard as a result of a median nerve injury?
Like gripping a glass or picking anything up with your hands, I guess. Gripping anything.
Yeah, it's kind of our prehensile nerve, right? It's the one that really helps us form prehension when you think about it. It's very important for prehension. Yeah, feeding again would be hard, holding onto utensils. But when you think about it, it's kind of our prehension nerve. Okay. So anything that requires prehension, anything that requires pinch, palmar pinch, tip pinch, to some extent lateral pinch. Okay. Okay. How are we doing? You guys doing okay? we still have quite a few slides to get through, so yeah, take a short break, like 5 minutes, and then we need to get through some more slides. We still have an hour here, or 45 minutes. Okay, so take like a 5-minute break. I'm going to pause the recording here, and then we'll come back. Okay, so 5 minutes, that means that, according to my clock, 10:52, we'll come back. Okay, so we should get going. We're going to start talking about the radial nerve now. So the radial nerve, as you recall, branches from the posterior cord of the brachial plexus. Okay, and it sends off three branches kind of at the level of the axilla. Okay, where it innervates the posterior cutaneous nerve of the arm, and then it sends off a branch to the long head of the triceps, and it sends off a branch to the medial head of the triceps. Okay. And then it travels between the long head of the biceps and the humerus, and then it goes medial to lateral, so it starts moving out laterally, and it basically travels through what's called the spiral groove of the humerus right here, okay? And it travels between the lateral and the medial head of the triceps as it does that, okay? And this is actually the location where it's prone to injury during a humeral fracture. So if the humerus is fractured right through this area, it's very prone to injury because it's so close to the bone. Okay, and it branches as it goes through the spiral groove into an inferior lateral cutaneous nerve, a posterior cutaneous nerve, and then it sends up a branch to the lateral head of the triceps and a branch to the medial head of the triceps there as well. Okay. And then it continues and moves off laterally and comes out and actually travels between the brachialis and the brachioradialis on the anterior side of the lateral epicondyle. Okay, so anterior to the lateral epicondyle. And it's at this point where it it innervates the brachialis, the extensor carpi longus, and the extensor carpi brevis. Okay, and then it continues on its way and actually branches off to form a superficial sensory branch and a deep branch of the radial nerve. Okay, the deep branch becomes what's called the posterior interosseous nerve after it crosses through the supinator, and that is strictly motor in nature. It's just a motor nerve, and we'll talk about what it does. And the superficial branch actually is just sensory in nature. It just gives us sensory information to the backside of our hand. Okay? So, and this is a nice stripped down model right here where it kind of illustrates this. So here after it, goes to the spiral groove, comes down here and innervates the brachioradialis kind of at the, here's the lateral epicondyle right here, so it's a supracondylar ridge in this area where it innervates that. Then also the extensor carpi longus, extensor carpi brevis, okay? And then it travels through the supinator and sends off a posterior interosseous nerve. So this is what's called the posterior interosseous nerve right here. And it innervates the supinator, the extensor carpi ulnaris, the extensor carpi or extensor digitorum, the extensor digiti minimi, abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, and extensor indicis. Okay, so it has motor function basically of the supinator and all these other muscles that are radial and nerve innervated distally. And that sensory branch comes off and gives us sensory information to the radial side of our hand. Okay, and that's what it looks like right here. This is where the superficial branch of the radial nerve gives us sensory information from. Okay, and it's very superficial, thus its name, and it's prone to irritation in this area right here. So splints and casts can actually cause, because of friction and compression, can actually irritate the nerve in this area. So, commonly injured, like I mentioned, is mid-shaft of the humerus, okay? And that leads to a full-blown radial nerve palsy, where a person's going to have weakness in extending the elbow, they're going to have weakness in extending the wrist, and weakness in extending the thumb, and weakness in extending the fingers, okay? Another way that it might be injured is that the posterior cord could actually be injured in the axilla due to the use of crutches. So like a person who's a prolonged crutch user, or an adult perhaps that's been using crutches, axillary crutches, because they have something like cerebral palsy or something like that. And also in the dorsal proximal forearm, okay, so where the radial nerve kind of goes through what's called the radial tunnel, which is basically the space between the radial tunnel is the space between the radial head and the supinator, that distance essentially, which is hard to, but it's that distance that the nerve travels through there that's called the radial tunnel, and it's prone to being irritated there. And then the posterior interosseous nerve is actually prone to be irritated at the distal edge of the supinator. So as it travels underneath the supinator and exits there, on the distal edge of the supinator is a place that it can get rubbed and irritated. And as I mentioned earlier, because the superficial branch of the radial nerve is so superficial at the level of like the wrist and the back of the hand, it can be irritated there as well due to compression. So those are the places. Of course, they can be completely cut, back here due to direct trauma. It can be cut in other parts of the arm too due to direct trauma as well. So, question for you is, which hand on the left here was injured, has a radial nerve injury? This is an easy one.
Closer to the sink in the back.
Yeah, okay. And why do you think that is? What do you see happening?
The person can't extend their wrist or like keep their fingers extended out, or their thumb.
Right. So they're not able to extend their wrist. They're not able to extend. Yeah, they have wrist drop. Okay. So they're not able to extend the wrist. They're not able to extend their metacarpal. You can't see this, but they're not able to extend their metacarpal, their MCP joint, very successfully either. Now, that's a picture of a person that's had a high-level radial nerve injury. So a picture that's had, like a person, let's say, that actually had a fracture right here, right? Where the extensor muscles that are, the wrist extensors that are innervated, just at the level of the epicondyle, the lateral epicondyle or so, aren't working as well as everything else from that point forward, okay? The brachioradialis would also be weak. What we see on this picture right here is a different scenario. This is a person with a radial nerve injury, but you'll notice that they are actually able to extend their wrist, right? The wrist isn't in a drop position. Where do you think this sort of injury is occurring? On the right here. Because the wrist extensors are still working, okay? But a person can't extend here, and their thumb isn't able to extend either, okay? So thinking back.
Like with a superficial branch?
Well, the superficial branch is just sensory.
Okay.
So we're seeing something happen from a motor standpoint. But you're on the right track in that it's happening more distally, okay? What nerve do you think in this particular case that we learned about that is a branch of the radial nerve is likely not working? There are two branches of the radial nerve, right, after it travels into the forearm. There is the deep branch, which becomes the posterior interosseous nerve, and there's the superficial sensory branch. Well, there's a motor problem here, so it can't be sensory in nature, necessarily. So we're talking about a problem with the posterior interosseous nerve, is what we're seeing. Why is that? Well, the person, as we saw in the photo, has wrist extension, which means that the extensor carpi radialis longus and brevis are likely doing their work, right? So they're still innervated by, so if that means that they're still innervated, we know that the injury can't happen to the nerve at this level, right? It didn't happen up here at the midshaft because these two are still working, right? So that means that if we're seeing the ability to extend the wrist, these two muscles are still working, right? So that means that the injury has to be to the nerve distal to those, right? And what we see happening is we see this person having a hard time extending their metacarpals, which is the responsibility of the extensor digitorum, right? That's not happening. They're able to extend the wrist, but they can't extend the metacarpal of the hand, right? I'm sorry, the proximal phalanx. They're not able to extend the proximal phalanx of the hand, okay? The other thing you see happening is that the thumb is tucked into itself, which means that these thumb muscles that are responsible for extending and abducting the thumb aren't working, right? So this injury right here is an injury to the posterior interosseous nerve. The wrist is able to extend. The thumb is not able to extend or abduct very well, right? And you'll see that the thumb tip is actually posturing in flexion as well, and that's because the extensor pollicis longus isn't able to extend the IP joint. And then the other thing you see happening is that the extensor digitorum muscle, which comes and inserts right here at the base of the proximal phalanx, isn't doing its work in extending the fingers like it is over here. Okay? What we do see happening in this person is that they're trying to open their hand by extending their IP joints, right? So what muscles extend their IP joints? What muscles produce extension of the IP joints in the hand? They also flex the MP joints. They make this happen. They're intrinsics. So your lumbricals and your interossi are responsible for straightening the IP joints and flexing the MP joints. That's what they do. So they make this happen. This is called an intrinsic plus posture, meaning that the intrinsics make this happen. So the interossi and lumbricals make this happen. So this person is trying to open their hand by activating the ulnarly and medially innervated the lumbricals and interossi, right? The posterior interosseous nerve isn't working. They're not able to open their hand here where the extensor digitorum inserts onto the proximal phalanx. They can't do it. So he's trying to open it up through the use of his interossi and his lumbricals. Does that make sense?
Could you repeat what you said, the lumbricals and interosseous flex and extend? Which
yeah. So the palmar and the dorsal interossi have two functions. Palmar, right? They adduct the MCP joints. They bring them together. They bring the fingers together, like this, right? The dorsal interossi also, they do the opposite. They abduct. So they dab, right, which has taken on new meaning, right? They dab, right? Whereas the palmar interossi, they pad. They adduct. So dab, pad, right? The other thing that the interossi do is they flex the MP joint and they extend the IP joint. And this gets into the extensor mechanism, which we're going to come into pretty quickly, right? So that's what this person is doing. They're trying to pull in their interossi, and their lumbricals also, flex the MP joints and extend the IP joints. Okay, so this person is trying to use the lumbricals and the interossi to extend their hand the best that they possibly can, and the only way they're able to do that is not here at the MP joints. They can't extend the proximal phalanx because the extensor digitorum comes down and inserts right here. It's not working, right? So the best they can do is just pull their interossi and their lumbricals in to try to open up the distal part of the hand. That make sense?
Yeah, thank you.
Mm-hmm. Okay. So things that we might do from a rehab standpoint for people that are having like compressive problems to the nerve is we might do some preparatory things. We might actually help to loosen up the muscles that the nerve travels through, right? We might teach them how to change behavior. So that's like what we might call joint protection type of behavior, where if they're overusing the muscles that border where the nerve travels through in the forearm that irritate it, we might teach them some stretches. We might teach them how not to overuse those muscles. And in some cases, we might actually make an orthosis to allow the tension that's being created on the nerve from a compression standpoint to relax. So this person's actually being placed into supination and some wrist extension because the supinator, like I mentioned earlier, can irritate the nerve. And so by taking pressure off the supinator, by putting them into more of a supinated posture, because the supinator gets stretched out when you're in pronation, whereas if you put them in a posture like this, it's not being stretched so much. So this person is just being splinted to help resolve some of the irritation of the nerve. Surgeons might inject that area with cortisone. And then in some extreme cases, here you can see the posterior interosseous nerve right here. That's what this white thing is. And then right up here is the supinator. And this, in this case, the supinator is being cut to relieve pressure on that nerve. Okay, so that's what they're doing right here. They're doing a cut to the supinator to help relieve tension onto the posterior interosseous nerve. Okay, so those are some things that can happen. So here's some cool images that I pulled together. This basically just illustrates what happens when a nerve is injured. Okay, and I talked a little bit about this earlier. You're going to get more into that later. But this is kind of an illustration of the type of surgery a person might have to repair a nerve that was damaged after a humeral fracture. So you can see this green portion of the nerve. This is the radial nerve that formerly went right through the spiral groove back here. And it was cut after this person fractured their forearm. Okay, and it was damaged severely. So what the doctor did is they actually borrowed a cutaneous nerve from somewhere else in the body, and they bridged that gap from this end of the radial nerve to this end of the radial nerve with that borrowed portion of the cutaneous nerve, which means that they're going to lose cutaneous sensation someplace else that they borrowed it from. But it was likely an area where you don't need it, right? Like maybe on the lateral forearm or something like that. And then they basically connect the nerve to itself so that the axon that was damaged at this level right here still has a tunnel to send its nerves through as it's healing. So this is the process. The nerve gets injured, and then macrophages, things like that, come in and they start cleaning up the mess. And then if there's a nice sheath, which is the epineurium of a nerve on the outside here, then those new sprouts, those new axonal sprouts that are coming back through there can find their way home. So that's what the surgeon has tried to do right here, is recreate a tunnel for those axons to find their way home. And their home obviously would be back into the extensors of the elbow, the extensors of the wrist, the extensors of the extensor digitorum, the extensors of the thumb, and then of course the sensory information that it provides as well. That's its home. Okay, and then what we might do in the meantime, as that nerve is working really hard on finding its way back to its home, is we might help a person compensate for the lack of motion that they're no longer able to produce because the nerve isn't innervating the muscles. Okay, so that's what we're doing right here with this particular intervention. Right, this is a wrist drop orthosis. Okay, so it crosses the wrist joint and maintains the wrist in extension, and then it has these little outriggers out here that pull the thumb out into abduction, into extension, and pull the fingers up into extension. Right, and something for you to try at home or wherever it is that you're connecting from, is try to, like, I don't know, if you have something nearby that you can grip onto, try gripping it with your wrist first into extension and see how hard you can grip it. You can grip your other hand if you want. And then drop your fingers down into flexion like this and try to grip the same thing again as hard as you possibly can. So, in which instance, the wrist extended or the wrist flexed, did you feel like you were better able to grip that object or yourself?
Extended.
With extended, right? Yeah. And so when your wrist is flexed like this and you try gripping, you've made the wrist flexors actively insufficient. Okay, so you've made those wrist flexors extend, or their finger flexors contract down to a very short position where they're less likely able to exert a force, where their actin-myosin complex is less likely, is less capable of generating force, right? Because they're it's so closely overlapping one another, the actin-myosin complex, right? And so that's the benefit of this particular orthosis, is that it allows the person to extend their hand and extend their wrist and their fingers so they're better able to grip. Without it, you've made the flexors actively insufficient and you've made the extensors passively insufficient. Okay. So, what do you think this particular orthosis would be ideal for? Either a posterior interosseous nerve injury or a high level, like a radial nerve injury at the level of the humerus, like we've shown. Which of those two scenarios do you think this one would be good for? And why?
Again, I would say that it's a high radial nerve injury because it's pulling the wrist back up into extension again.
It is pulling the wrist into extension, but it doesn't offer any support to the wrist per se. So the other orthosis that I showed you earlier crosses the wrist joint and provides really a lot of stability to the wrist, whereas this one doesn't. So this actually would be a nice orthosis for a person that actually has the ability to extend their wrist, because it's not restricting the wrist. This person can still actively extend their wrist. The true benefit to this particular orthosis is it's still providing assistance to the metacarpals and to the thumb, so that, or to the proximal phalanx of the hand, to extend the proximal phalanx of the hand, and then also an outrigger out here to provide some abduction and extension to the thumb. It doesn't provide much help. I mean, it does indirectly support the wrist through this piece, but it doesn't actually have any stabilization of the wrist. So this actually would be ideal for a person that doesn't need as much support of the wrist, that has like a posterior interosseous nerve injury, that actually can extend their wrist through the use of their extensor carpi radialis longus and brevis, but can't extend their fingers because their extensor digitorum isn't working, and can't extend or abduct their thumb because extensor pollicis longus isn't working, abductor pollicis longus isn't working, extensor pollicis brevis isn't working. Does that make sense? So yes, it does indirectly support the wrist, but it doesn't provide rigid stability to the wrist like a person with wrist drop would need. Okay. So this is kind of like beating a dead horse, but I think it's good to review again. Let's say with a high radial nerve injury, what motions would we expect a person to have? So a radial nerve injury up here, right, before it enters the elbow. What sort of motions would be weak as a result of an injury like that? Extension. Yeah, so lots of extension. That's the radial nerve's primary job, is to extend, right? So it extends the elbow, it extends the wrist, it extends the proximal phalanx of the index through the small finger. It extends the IP joint of the thumb. It extends the MP joint of the thumb. And it abducts the carpal metacarpal joint of the thumb. It does all those things. So the only time it has any other, and then it does one other thing at the level of the elbow, essentially. It helps to supinate as well, right? Because it innervates the supinator as well. Okay. So a person could have weakness in supination, although they'll still have their biceps. They could have, obviously, they're going to have wrist extension weakness. They're going to have some elbow flexion weakness too, because the brachioradialis is going to be weakened. So it's going to take that out of the equation a little bit. They're going to have some weakness in the extension of their proximal phalanx, of their index to their small finger. So they're going to have weakness in thumb extension too. So lots of it's very profound. It has very profound effects. The sensory changes will be pervasive as well, depending on how high the injury is. But the radial nerve and all of its cutaneous branches, gives us sensory information basically through here, except for the ulnar innervated stuff out here. But it's pervasive. And so the impact on occupational performance is also profound. There's so many things that we need to extend our elbow for, that we need to supinate our forearm for, that we need to extend our wrist for, that we need to open our hand for grasp. I mean, it has potential to be profoundly devastating in terms of occupational performance. Mostly because the purpose of a lot of when you truly think about it, the purpose of the wrist extensors and the finger extensors is really to kind of pre-position the hand so it can do its work on gripping. That's when you really truly think about it. Being able to open up your hand and being able to extend your wrist, its main purpose is so that we can pre-position, that we can get the hand in a position where it actually can do its work to exert its force in gripping. Right? So if you take those muscles out of the equation, the ability to generate grip force, even pinch force, right? If my thumb isn't able to abduct, it's pretty hard for me to create a pinch, right? If my thumb is in on its side like this, it's pretty hard for me to pinch, right? So being able to get it out like this, is really important for me to be able to generate enough force to actually pinch. So it's big. It's very profound. Does that make sense? Any questions about that? Okay, so we need to keep on moving. So the next thing I wanted to talk about is the extensor mechanism. And this is a fascinating thing. We're going to talk about that right before we transition into the ulnar nerve. Right? So, so the extensor mechanism has the following components to it. Okay, so it has the extensor digitorum tendon, which is this tendon right here. Okay. Then it has the sagittal band. The sagittal band goes right over top of the MCP joint of the second digit, third digit, fourth digit, fifth digit, right? And it keeps this extensor tendon right over top of the joint. It keeps it from sliding this way or this way. That's its job, okay? Then we have a central slip. Okay, so the extensor digitorum tendon comes in and inserts down onto the base of the proximal phalanx, like right here. And then it sends down a central slip right here that inserts into the base of the middle phalanx, right? It also, the extensor digitorum also sends off lateral slips. So that's what these are right here. These are called lateral slips. So the extensor digitorum tendon basically splits into 3 parts after it inserts onto the base of the proximal phalanx and sends off 2 lateral slips and a central slip. Okay. the central slip, like I said, comes down and inserts on the base of the proximal, or the base of the middle phalanx. And these lateral slips come in and insert on what's called the lateral bands. That's what this thing is right here. Okay, these lateral bands of the extensor mechanism. Okay. So the lateral bands are, this is important, are where the lumbricals and the interossi attach to. Okay. So this is a side view that illustrates that. So here we see the interossi muscle, right, coming in, inserting onto the lateral band right here. Here we see the lumbrical muscle coming in and inserting on the lateral band right here. Okay. So there are basically 3 muscles that are inserting onto each of these extensor mechanisms, right? Okay, as you can see right here. So here we see interossi on this side and on this side, inserting onto the lateral band on this side as well, right? And they will be dorsal and palmar interossi doing this. Palmar being this one, dorsal being this one, right? Because in this case, the dorsal interossi are going to abduct the thumb as well, so they're on this side of the finger. And the palmar interossi are going to adduct the thumb, or the finger, and pull it this way. So this would be a palmar, and this would be a dorsal. Okay? And then we've got the lumbrical muscle. And the lumbrical muscle always comes in and inserts on the radial side of the finger. Right? So we have 3 muscles that are coming in and inserting onto this, these lateral bands. Okay? And then we have the terminal insertion. So these lateral bands, they come back together and they insert basically on the base of the distal phalanx. Okay? And the last piece that we have is called the oblique retinacular ligament, which I'll get into in the next slide or so. So those are the components. Okay? I love these diagrams because what they do is the black arrows right here illustrate the forces being generated by the extensor digitorum muscle, and the red arrows illustrate the forces being generated by the lumbricals in the interossi. It's beautiful. It's a really cool thing. Okay, this is a precious find. Okay, so the extensor digitorum, as it does its work, like I said, it first inserts on the base of the proximal phalanx, so it helps to extend it, and then comes down through the central slip and inserts on the base of the middle phalanx. So the extensor digitorum helps to extend the middle phalanx and the proximal phalanx. Okay, and then because these interossi, this interossi muscle and the lumbrical muscle, come and insert on the lateral band creates tension on this entire extensor mechanism and pulls it back this way. Okay, so it pulls it back this way, and because those lateral bands come in here and insert on the base of the distal phalanx, it helps to extend the distal phalanx. Okay? I mean, it's a very complicated thing, but when you break it down, it makes a lot of sense. Okay, so I just love how these red arrows kind of illustrate that. The other thing that's important to understand is that here's the metacarpal joint right here, right? And so here you see the lumbrical and the interossi muscles coming underneath of the MP joint and inserting, like I said, on the lateral bands here, but they also insert on the base of the proximal phalanx. So because of that, they insert on the lateral bands, they do their work to actually extend through creating tension on the extensor mechanism, extend the IP joint, the distal IP joint, but they also flex the MP joint because they lie beneath the MP joint. And when they contract, they pull down the MP joint. So that's why this is called intrinsic plus. Okay? Because the interossi and the lumbricals are making this happen. They're intrinsic muscles. This is intrinsic plus. That's what we call this position. Okay? So the oblique retinacular ligament is the next thing I wanted to talk about, and that's this structure right here. It actually originates from, to some extent, flexor digitorum profundus, and comes underneath. This is the PIP joint right here. It comes underneath the PIP joint and then travels up here and enters into the back of the hand on top of the DIP joint. Okay? So what happens is, because of its line of pull, as the PIP joint moves into extension, it actually causes this to stretch. It causes pull on the oblique retinacular ligament, which increases tension on the dorsum of the DIP joint. So basically, it helps to extend the DIP joint when the PIP joint is also extending. So it kind of is a passive aid to helping the DIP joint extend when the PIP joint is extending. Okay, so it basically helps the lumbrical and the interossei do their work. Okay, and conversely, as the DIP joint flexes, it actually helps in aiding PIP flexion at the same time. Okay, because it creates passive tension on the PIP joint. So it's a very critical ligament because it can become tight and actually a big problem in certain conditions like a boutonniere deformity, which we won't get into at this point, but you'll learn more about it. Okay, but it contributes to the extensor mechanism. Okay, so it's basically a passive assist to extending the DIP joint when the PIP joint is extended, and it's a passive assist to flexing the DIP joint when the PIP joint is flexed. Okay, and this just kind of helps to better illustrate. Here are the lumbrical muscles. Okay, so here are the radial two lumbrical muscles, which are just basically pennate, and the ulnar two, which are bipennate. And how they insert onto the radial aspect of the extensor mechanism. Okay. And then here you can see the first dorsal-interosseous muscle right here, and it inserting onto the extensor mechanism. Okay. So I've already mentioned that when the lumbricals and the interossei generate their force, they help to extend, they create tension on that extensor mechanism to extend the IP joint. Okay. Another thing that can happen is that when you just drop your fingers into this position, just go ahead and do this at home, or wherever you are, flex your MP joints. And what happens to your IP joints when you do that automatically? What direction does it make your IP joints go when you just bring your MPs down into flexion? Does it make them extend or make them flex? Just at rest.
Extend.
Extend, yeah. And that's because you've created passive tension on the extensor mechanism. You've made that tension. You've just created tension on the extensor mechanism, and passively, it just creates tension and pulls the IP joints into extension just passively, even without much contraction of the lumbricals or the interossei. Okay? So that's its primary function. The extensor mechanism's primary function is to help extend the IP joints. Right? And I wanted to talk about that before we talk about the ulnar nerve, because the ulnar nerve ultimately ends up innervating the lumbricals, two of the lumbricals and all the interossei, right? So to understand how it works, it's really important to understand how the extensor apparatus works, or extensor mechanism, okay? All right, so the ulnar nerve comes from the medial cord of the brachial plexus. It lies basically near the brachial artery in the anterior compartment of the upper arm, right here, okay? And for those of you that have to go, feel free to, because I think we're approaching our time. If you guys have to go, I'm going to keep talking, and I'm going to record this, and then you certainly can listen to the very end of the recording at a later time. But if you have to scoot off, feel free to do that. I'm going to stick around and finish this lecture, okay? It sticks in the anterior compartment of the upper arm, and it travels basically medial to the triceps, Okay, so it travels right through here near the triceps, but medial to them. And then it's going to go behind, basically behind the medial epicondyle through what we would call the cubital tunnel. Okay, and the cubital tunnel, its roof is a ligament, and then it also is formed on the medial and the lateral side of the tunnel by the two heads of the flexor carpi ulnaris. Okay, and then also by the elbow joint capsule. But anyways, the nerve travels through this little canal through there, right? Our funny bone nerve, and then it enters, like I said, between the two heads of the flexor carpi ulnaris, and runs between the flexor carpi ulnaris which is gone in this, it's right here. Here's flexor carpi ulnaris. Okay, so here you can see it traveling right there. It's between flexor carpi ulnaris and flexor digitorum profundus. So superficialis is taken off of this photo. So here's profundus, and here is flexor carpi ulnaris right there. So there it is traveling between the two. Okay. It's before it goes into the wrist, it's going to send off a dorsal sensory branch. Okay, so that's what it shows itself doing right here. It's going to send off a dorsal sensory branch, and that's going to go around to the dorsal aspect, and it's going to be what gives us sensory information right through here. I'll show you this in another slide, but on the back side of our hand, on the ulnar side of the back side of our hand. Okay, that's before we get to Guillen's canal. Okay, so Guillen's canal is the tunnel that's formed right here at the level of the wrist, and it's also partially formed by that transverse carpal ligament, like with the carpal tunnel. This is kind of an extension of that transverse carpal ligament, and there's the ulnar nerve going right through there, and it's bordered by like the pisiform and by the hook of the hamate bone, right? Those are kind of its borders on medial and lateral sides, as well as that ligament on the top of it. So it's prone to being irritated right through this tunnel, kind of like the median nerve as it goes through the carpal tunnel. It's prone to being irritated right here. Okay, so after it travels through Guillen's canal, it's going to send off a superficial branch, and this is on the palmar side of our hand, and a deep branch. The superficial branch is cutaneous. It's what gives us basically cutaneous information from the ulnar palmar side of our hand right here. Okay. The deep branch is motor, and the deep branch first comes over here and innervates our hypothenar muscles, right, which are also OAF, opponens digiti minimi, abductor digiti minimi, and flexor digiti minimi. Okay. And then after it's innervated those muscles, it's going to innervate the ulnar two lumbricals, so the lumbricals that go to the ring finger and the pinky. And then it's going to innervate all the interossi. It's going to innervate the dorsal and the palmar interossi. And then lastly, it's going to find its way all the way back over to the thumb side of the hand, and it's going to innervate the adductor pollicis, and it's also going to innervate the deep head of the flexor pollicis brevis. Okay, so the median nerve gets the superficial head of flexor pollicis brevis, but the ulnar nerve gets the deep head of flexor pollicis brevis. So it's a thenar muscle that has dual innervation. It's got innervation from the ulnar nerve and from the median nerve. Okay? And this is just a diagram that helps to illustrate that. Okay, so after, at this level, the ulnar nerve innervates like a flexor carpi ulnaris and innervates the part of the flexor digitorum profundus that goes to the long finger, or to the ring finger and the small finger. And then also comes down and innervates the hypothenar muscles, innervates, the lumbrical muscles to the ring finger and to the small finger, and innervates the interossi as well, okay, dorsal and palmar, and then likely finds its way back over to the thumb and innervates the deep head of flexor digitorum, flexor pollicis brevis, and the adductor pollicis. Okay, adductor pollicis. So this is what that dorsal branch that exits before it gets into Guillen's canal. This is that cutaneous innervation that it provides. And then the superficial branch of the ulnar nerve on the palmar side gives us this. Okay, after it crosses through Guillen's canal, it gives us this information here. Okay, so it's the palmar cutaneous branch, and it gives us this information here. Okay. Problems with the nerve. It can be irritated, like I mentioned, right through Guillen's canal, which is right here. So here's that transverse carpal ligament, an extension of that. And here the nerve is traveling underneath of there, and there's pisiform and hook of the hamate over here. So there it is traveling between those two bones and underneath this ligament. And it can be irritated right here due to compression. Cyclists will sometimes experience this. As they rest their hand on the ulnar side of the bike, the handlebars of the bike. It can also be cut or transected in that area, like the median nerve can be. It's prone to being injured there as well. So when it's just being compressed at the level of Guillen's canal, like with the median nerve, we as an OT might help to decompress it by keeping them out of those awkward postures that compress the nerve. So this would be a similar orthosis that we would use like in median nerve on compression to take pressure off the nerve as it goes through Guillen's canal. We'd also teach them perhaps some preparatory interventions that might help to stretch some of the structures and to make the nerve glide better through that area. I won't get into that. A surgeon might also inject some cortisone into that area to help reduce the inflammation on the nerve. Excuse me. And then the cubital tunnel is another place that the nerve is prone to being injured or irritated, right? So when you wake up at night, perhaps with the pinky side of your hand numb, and you've probably been sleeping something like this, that's because the ulnar nerve is not getting enough blood flow to it because you've put it into an awkward posture like this, and it's causing tension on it and decreasing blood flow to it. So what we as a therapist do, and that's called cubital tunnel syndrome. So, I mean, it's a normal thing to happen, but it can get into extreme issues where a person has really, really bad problems with sensation on the pinky side of the hand. And then also eventually weakness in some of the muscles innervated by the ulnar nerve. Excuse me. These are some things that we do, like conservatively. We might make an orthosis to make sure they don't adopt those awkward postures when they sleep, or don't put pressure on the cubital tunnel. Like when a person rests on the tabletop and is working at, typing and things like that, perhaps providing them an elbow pad to take pressure off the cubital tunnel as it travels through that very superficial area, or as the nerve travels through that very superficial area. What a surgeon might do, if this gets to be a bad problem, is they might actually just take the nerve out of the cubital tunnel and transpose it. Okay, so this is called a transposition, where they actually take it and they remove, they cut some of the flexor muscles away from their origin, and then they put the muscle underneath of them, and then they reattach the muscle to the tendon. The reason for doing this is that it takes the nerve out of that tunnel that is irritating it, and it puts it into a safer position. So this is actually called a transposition, an ulnar nerve transposition. So that's what's done in like extreme cases when that cubital tunnel syndrome is really bad. Okay, so tell me, this is an ulnar. This is what a person might look like with a laceration at the wrist, or really, really bad compression at the wrist. Okay, which of these two fingers on the top here, for those of you that are still with, is likely affected by an ulnar nerve injury at the level of the wrist? This one or this one? So the one with the flexed thumb or the one with the extended thumb tip? Just go ahead and guess.
Extended.
Okay. Any other guesses? So it is, in fact, the one with the flexed thumb. And the reason for that is, and this is called Froment's test. This is called Froment's test. But this person right here, what they're doing is they're adducting their thumb. They're adducting their thumb as they pinch this piece of paper. This person, they're being asked to adduct their thumb as they pinch the paper, just like this, like a lateral key pinch. But they can't because their adductor pollicis isn't working, right? And that's because it's ulnarly innervated. So what they do to compensate for that is they use their flexor pollicis longus to adduct the thumb. So they're basically using the long finger flexor to substitute for the lost function of the adductor pollicis. So this is called Froment's test or Froment's sign. Why do you think in this particular issue down here the hand is posturing like this? We just talked about the extensor mechanism and the action that the lumbricals and the interossi take on it. So why do you think the hand is posturing in a claw like this when the ulnar nerve is injured?
Because it's not supplying to the deep branches that supply those nerves or those muscles.
Right. The deep branch isn't sending its messages to the interossi or the lumbrical that tug onto the extensor mechanism that cause the IP joints to extend. So this person can't extend their IP joints, right? The extensor digitorum can extend the proximal phalanx because it's still working, but the ability of the lumbricals and the interossi that are innervated by the ulnar nerve to act on the extensor mechanism have been diminished, right? And so what's happening here is there's an imbalance of strength. You've got the flexor digitorum profundus coming in and tugging because it just naturally creates tension on the distal phalanx. It's tugging, and then the lumbricals and interossi can't put up a fight against that. So that's why a person gets pulled into this position, okay? This is called a claw hand deformity or an intrinsic minus position, okay? So this is intrinsic plus, like I mentioned earlier, and this is intrinsic minus. If a person had combined median and ulnar nerve injury, then intrinsic minus would look like this, right? Because the median nerve supplies the lumbricals on that side of the hand too, so they would really truly have an entire hand affected by a claw hand like this. Whereas if it's just the ulnar nerve, the person can still extend their IP joints because their lumbricals on the median side are still working, but they can't extend their IP joints on the ulnar side of the hand. Okay, so this is what a surgeon might do. They might actually just repair that nerve if it's been cut, or they might actually release Guillen's canal if it's just being compressed. And this might be something that we would do as a therapist to help substitute for the interossi and the lumbrical that aren't working. Okay, so what this does is, like we talked about earlier, when you put your fingers into a flexed position like this, it passively creates tension on the extensor apparatus or the extensor mechanism, right? So that's what this orthosis does. It actually blocks a person from moving the MP joints into extension and passively creates tension on the extensor apparatus, which increases extension of the IP joints. So this actually is what's called an intrinsic plus type of orthosis. And this bar right here has been named a lumbrical bar. And we name it a lumbrical bar because it substitutes for the effects of the lumbrical. When the lumbricals aren't able to do their work, and in this case also the interossi, adding this little bar to block extension of the MCP joints actually creates tension onto the extensor mechanism and helps us extend our IP joints when we otherwise couldn't. Okay, and that's really important because to extend those IP joints allows for us to open our hand up sufficiently so that we can grip things. If it's not there, then when we try to open our hand up to grip something, it's going to look like this. And we can't get these fingers open up enough around something to grip. So this type of orthosis really helps to enable hand function. Okay, so we're kind of running out of time. So the motions that a person is going to have a hard time doing, depending on how high the nerve has been damaged, if it's been damaged all the way up kind of at the level of the elbow, where the flexor digitorum profundus is going to be innervated, and also the flexor carpi ulnaris is going to be innervated, then certainly we could have problems because the flexor digitorum profundus flexes the DIP joints to the ulnar side of the hand. We would have problems fully flexing our fingers into this position. We would also have weakness in wrist flexion because the flexor carpi ulnaris flexes our wrist, and we would also have weakness into ulnar deviation because the flexor carpi ulnaris ulnarly deviates our wrist. So we wouldn't be able to produce this very easily. Okay. Also, out further distally, we would have problems with all the hypothenar muscles of our hands, right, which abduct the pinky, abductor digit minimi, flex the MP joint of the pinky, flexor digit minimi, oppose the pinky to the thumb, so opponens digit minimi, right? We would also have weakness in our inner ossi, so we couldn't abduct. It would abduct our hand or adduct our MCP joints. We'd be weak there. Okay, and then we'd also have problems adducting our thumb because adductor pollicis wouldn't be working, right? We would also have some weakness in flexing our MP joint because the deep head of the flexor digitorum or flexor pollicis brevis would be gone. And then we would have a hard time creating this intrinsic plus type of posture as well, right? We would tend to posture into like a claw like this because our lumbricals and our inner ossi aren't working. We would have sensory changes on the palmar and the dorsal part of the ulnar side of our hand. And from an occupation standpoint, again, grip would be influenced because the lumbricals and the inner ossi actually help to produce grip. If it was higher up, the flexor digitorum profundus helps to produce flexion and grip of our hands, so grip would be affected. The ability to laterally pinch, we use lateral pinch quite a lot to hold onto a key and to turn it, to hold onto a book like this. We use a lot of lateral pinch, right? The ability to laterally pinch would be impacted because the adductor pollicis contributes to that. So it would definitely influence hand function, okay, and our ability to carry out occupations that require those types of hand functions. Okay. The last thing that I'm going to talk about is just a long thoracic nerve injury, okay, or the long thoracic nerve. Okay, so a long thoracic nerve basically, unlike other terminal branches, actually originates from roots, nerve roots. Okay, so it comes off of C5, C6, and C7 nerve roots. Okay, and then just like the brachial plexus, it travels through the scalenes and travels underneath the collarbone and underneath pec minor and comes down here and innervates the serratus anterior muscles. That's what the long thoracic nerve innervates. Okay. So it can be injured for a variety of reasons. After an individual has had a mastectomy, for example, for cancer treatment, stab injury, someone's been stabbed to the side over here. When they place a chest tube in someone to help them with, they have like pneumothorax or basically extra fluid around the lung cavity. They put a chest tube to relieve the pressure. Other thoracic surgeries, can end up damaging it if you have a surgery over here to the side. And then the cranial nerve root, if it's compressed, if C5, C6, C7 cranial nerve roots are compressed, it can cause problems with its function. It can be compressed the same way that the brachial plexus can be compressed throughout that outlet, the thoracic outlet. Okay, and that can happen. And sometimes people will be carrying straps on their shoulders, and that'll actually result in compression on that long thoracic nerve as it goes through the thoracic outlet. The heavy straps on the shoulders will do that as well. And this is what it looks like. A person with a long thoracic nerve injury will have what we refer to as winging of the scapula, where it protrudes like this, and that's because the serratus anterior, when a person reaches, its job is to protract the scapula, but it's not keeping the scapula close to the rib cage. The other thing that the serratus anterior does outside of protraction of the scapula is upwardly rotate it, because it comes down here and actually inserts through here, and when it pulls, it actually pulls the inferior angle of the scapula upwardly like this. So this is upward rotation, rotated upward like this. And so in this person's case, not only is the scapula winging, but it's downwardly rotated. It's coming closer to the spine. That's what it looks like here. Okay? So like I said, we would teach people to do things from the therapy standpoint. We would teach people how to do things differently so that they avoid these compression on the nerve. We would also, perhaps from a preparatory standpoint, stretch the scalene muscles that is coming through and whatnot. A surgeon would go in and actually perhaps cut portions of the scalenes to relieve pressure on it as it travels through the scalene, for example. So that's what's happening here. The anterior scalene right here is actually being cut to relieve compression on the long thoracic nerve, which is right here. Right there. Okay? And if those things don't help, then sometimes reconstructions take place, and so surgeons, the pec minor isn't always necessary. They'll actually attach pec minor onto where the serratus anterior tendons insert onto the scapula, and that's called a tendon transfer. And pec minor will actually substitute for the serratus anterior. So pec minor will be used to substitute for serratus anterior's function. Okay? And so the motions that a person has a hard time doing is upward rotation and protraction of the scapula, which makes push-ups really hard to do, especially at the very end of the push-up. It would make reaching above your head very difficult to do because upward rotation is necessary for for reaching above your head. And there wouldn't be any sensory changes because this has no sensory function. And then the occupations could influence overhead type of activities. It could influence the ability to push. So if you have to open doors, if you have to push carts at work, things like that, there are lots of different things that it can influence from a functional standpoint. And these last couple slides are just supplementary. They're just basically helping you just better illustrations of some of these things. Like these are all cutaneous innervation patterns of the distal upper extremity for you to see in a really nicely color-coded graphic. And then this is a nice overview of when a peripheral nerve is injured, where it may happen, and the results of the injury from a motor standpoint as well as from a sensory standpoint. That's all I got for you. Any questions? Hopefully this was helpful. I know it was a lot, but it's definitely going to be needed moving into that case quiz. And I know this is a real muddy point for a lot of students. This is a very complex thing, and I wanted to spend some time talking about this. And so I will post this recording, and I think it might be useful for this course moving forward as well. But I hope it helped. And then basically, this is years of knowledge that I'm imparting on you, things that I've acquired even since being an OT student. I think understanding, obviously, how these problems manifest after a problem, after a nerve is not working correctly, also helps to illustrate the function of the nerve and the muscles that it innervates. So it's a nice application level type of learning. Okay, I know we're out of time. And so I will post this recording, and I'm sorry for those of you that chose to stay longer. I hope it was a good experience for you. And anyone that left this last half an hour or so, feel free to, I would encourage you to watch it, obviously. Okay, that's all I got. And so be safe today. I know what, so if you have to drive, be safe. All right.